The cutaneous branches of the medial and lateral plantar nerves will pierce the plantar fascia on the medial and lateral side right in here. So once in a while you'll find that the cutaneous nerve will be trapped like there, and you'll get a tingling, a burning, or numbness on the skin, and you'll have to work the plantar fascia right at the point where the nerve pops through. So I'll be in this area right in here, not on the aponeurosis, but on the plantar fascia. I'll shorten all this up and then extend it, and I'll concentrate my tension right on the little knot that I'll find, if that is indeed the case, where it's caught where the nerve comes through. So I'll do that medial plantar fascia and the lateral plantar fascia right where the nerve comes through. The medial cutaneous nerve will pass through the aponeurosis, or the covering of the flexor retinaculum rather, and where it pierces the retinaculum can become an entrapment site. So we'll basically do a treatment on the retinaculum, but we're going to concentrate right where we feel the nerve comes through. If you can't feel it in a normal person, you'll probably be able to feel it if the entrapment is actually there. The patient may be able to put your finger right on it. But when it's bad, you can usually feel it. So I'll do the retinaculum treatment, concentrate right where the nerve comes through, and make sure that you hold some tension at the very end to kind of pull the retinaculum away from the nerve. Between the tibialis anterior and the extensor digitorum longus, you can find a spot midway through the low leg that you can get a little pressure on the deep perineal nerve. So we'll basically do a movement that combines that tibialis anterior and the extensor digitorum. So we'll dorsiflex the ankle, extend the toes, take our tension right in between those two muscles, fairly deep, proximal tension, and then have the patient plantar flex and flex the toes. At the end of the range of motion, you should be able to feel an area that pulls on a fairly narrow band, and that's going to be where the nerve entrapment is. The deep perineal nerve can get some pressure anywhere along its course in the middle leg, and one of those will be at the proximal end of the extensor digitorum longus. So we'll basically do an extensor digitorum longus treatment. Toes up, ankle dorsiflexed. I'm going to pick my spot where it's probably going to be tender, a little tighter in the spot. Proximal tension on the inferior side or the distal side of that knot, and then plantar flex and flex the toes. You may need to use a reverse tension on this, in which case it would be the same patient motions, pick my spot on the proximal side of that knot, and then exert a distal tension, plantar flexion, and flex the toes. For most of the course of the deep perineal nerve, the nerve will lie anterior to the extensor hallucis longus and a little bit medial to it. But down here, closer to the ankle, the nerve courses down into the dorsum of the foot, but the extensor hallucis longus will cross over to the big toe. So right in this area, you'll find that the nerve can be caught right at the extensor hallucis longus. So we'll pick that spot, kind of put a lateral pressure a little bit on the extensor hallucis, and then proximal. Start with it shortened, toe up, ankle up, and then proximal tension, and then plantar flex, and flex the big toe. The common perineal, superficial perineal nerve will course inferior and then right around the head of the fibula, about at the attachment site of the peroneus longus. And that's a potential site of entrapment. So we'll need to treat that area. It'll be a peroneus longus treatment, but we'll concentrate and try to move the peroneus longus forward or posterior a little bit, right where the nerve and the muscle cross. So we'll start with the foot down and out, or plantar flexed, and then move lateral or everted. I'll take my contact right where the nerve and the muscle cross, proximal tension, little bit posterior on the muscle if I'm on the anterior side, and then move the foot into dorsiflexion and inversion. And then if I need to, I can also do the back side of that muscle coming forward on the muscle with the same patient motions. And then also, if I need to, I can do it like the proximal peroneus longus attachment, and I can use a distal tension on the front or back side of the muscle. Okay. You may want to try all 4 of those directions to solve this problem. A common site of perineal nerve entrapment is this area between the heads of the hamstrings, the biceps femoris, and the lateral head of the gastrocnemius. So if you put your fingers right in between the two, you can often actually palpate the nerve where it's in between the two. So what I'm going to do is take 2 or 3 fingers, go in between, start with the knee flexed and the hip fairly neutral. Go in between the 2 muscles and then take a proximal tension. Now once I've done that, I'm going to flex the hip to about 90 degrees and then very slowly extend the knee. I have to be very slow because that nerve's going to pull tight all of a sudden. And if you go too fast and too far, it'll be quite painful, and then you won't be able to treat it anymore. So feel for when the tension is on the nerve and it's trying to slide through, and just push it a little by moving the leg until it starts to slide just a little bit, and then kind of reset and go back and forth. You won't get too many passes because there's a good bit of tension on the nerve when it's stuck there. So you'll get 2 or 3 passes on it, and then beyond that it'll start to get too sensitive. For posterior compartment syndrome, what you really need to do is treat the intermuscular septum. So it's not so much that you're prying tissue away from the nerve, is that you're getting the compartment to really let go and take the compression off of the nerve. So to do that, slide down just an inch. I'm going to have the patient plantar flex, and just like we explained with the intermuscular septum protocol, I'm going to go in, but probably right next to the nerve instead of off to one side. Press in fairly deep, take my tension, make sure I'm not compressing the artery or the vein, and then dorsiflex, help it if I can, and exert as much tension as I can on the septum without compressing on the vein or the artery or directly on the nerve. The posterior tibial nerve can be entrapped in the tendinous arch of the soleus. So I'm going to use a distal tension and motions and force the muscle and arch tissues inferior, and then I'm going to use a leg motion that brings the nerve proximal. So I'll fold up the leg like this, flex the hip, flex the knee, dorsiflex the ankle, and my tension is going to be just on the medial side a little bit, maybe just medial to the posterior tibial nerve, slide down the sheath of the nerve until I hit the tendinous arch, then hold the tendinous arch inferior. So I'll set up the leg first, then take my tension inferior. Now I'm going to flex the hip, extend the knee, plantar flex the ankle while I exert an inferior tension on the tendinous arch. So the nerve's going this way and the tendinous arch is going that way. The tarsal tunnel can be a site of entrapment. Usually one of the biggest problems is all the tissues don't really slide through the tunnel, and then they'll become involved by pulling on one another, so you get pressure on a nerve or lack of lymphatic drainage or one or more of those problems. So what I need to do is I'm going to trap the retinaculum proximal and then pull all the contents distal. So I'll start by flexing the toes, the arch a little bit, plantar flexing, and I'll be on the distal edge of the retinaculum and take a little contact, a little pressure, and then push that posterior and proximal. So I've got the retinaculum held that way, and then I'm going to dorsiflex and extend the toes, all of them, as much as I can while I hold that proximal tension on the retinaculum. The digital nerve as they course through the bottom of the foot, they'll branch once here and then branch a second time right in here to get on either side of each digit. The two places where they branch, and especially the distal one right in here, is a common site of entrapment. In order to treat those, I'll pick the appropriate spot, either down in the arch or up near the ball of the foot. I'll flex the toes, take a proximal tension in between the joints themselves, and then extend the toes one or two at a time while I exert a proximal tension. So I'm going to hold the bulk of the tissue proximal, and I'm going to use the toes to try to pull the nerves through and break up the tissue that's pressing on the area where they divide. And I'll have to do each section between the toes. Usually it'll be pretty obvious which one it is, because a typical symptom is you'll have numbness in between two toes, and you'll know that the site is going to be right there. The sciatic nerve can be entrapped right in the middle of the upper leg, underneath the hamstrings, or right in the area where the hamstrings divide to go to the knee. So between the medial and lateral hamstrings, if you just come up in between the muscles until they meet, then go in deep and take a tension proximal, deep enough to be close to the sciatic nerve. That's where the problem will most likely be. So I'll move the knee off the side of the table just a little bit, take my tension right in between the hamstrings, up in between the two, and then deep right against the nerve, but not compressing it. Take a proximal tension, and then have the patient extend the knee all the way while I hold the hamstrings proximal at that point. Usually about halfway through this motion, you'll feel the nerves start to pull underneath your contact. Now you may have to work it more effectively by getting a little bit more motion. So you have the patient lay on your side, on the right side, and my contact will be in the same place, right where the hamstrings meet, or maybe even a little bit higher. So you'll be just medial to the long head of the biceps, but in between the two sets of hamstrings, fairly deep. Just wiggle your finger around until you get fairly deep, and then you'll be able to find the nerve. And the patient will also know you're on the nerve once you get there. And that's the nerve right there. So I'll be right against the nerve, but not compressing it, and then I'll press fairly hard on the muscle, but not compress the nerve. So one side of the nerve or the other. And then I'll flex the hip and extend the knee, so I get a lot of tension actually on every structure, but I'm going to pull them apart with my contact. The sciatic nerve can be entrapped anterior to the hamstrings and posterior to the adductor magnus. The way we'll get there is we'll start roughly in the middle of the posterior thigh, but I'm going to be in between the long head of the biceps and the semitendinosus, and I'm going to go fairly deep, and then I'm going to move my thumb back and forth until I get in between those two, and I'll start to feel where the sciatic nerve is. What I want to do is just go off the side of the sciatic nerve and then press in a little deeper until I get to the adductor magnus, the back side, the posterior side of the adductor magnus. Once I'm there, I'm going to put my thumb right in between the nerve and the adductor magnus, and I'm splitting between the two hamstrings. Then I'm going to flex the hip, extend the knee, and maintain a proximal contact. So I really have all three or four in contact with my thumb: the medial hamstrings, the lateral hamstrings, the sciatic nerve, and the adductor magnus. The sciatic nerve can obviously be trapped at the piriformis, but probably just as common, it can be entrapped at the superior, inferior gemellus, and obturator internus. So we're going to address all of these together. It'll basically be a hip rotator move, but I should be able to palpate. Once the motion starts, I should be able to feel along the sciatic nerve and feel where, as the nerve moves, it pulls the muscle with it. So I'll do this motion with my hand and put my thumb right over the sciatic nerve and feel the inferior gemellus, obturator, superior gemellus, piriformis, and feel where I get the most tension distributed to the muscle from the nerve as the nerve starts to go. So then I'll concentrate just on the inferior side of that, whichever muscle that happens to be, and I'll hold the tension proximal, so I'm holding the muscles proximal, and then the patient will flex the hip while I hold that. And once I've done a couple passes and this loosens up a little bit, then I'll want to have the patient flex the hip and then extend the knee to get the nerve to slide out from underneath those muscles or over those muscles. Now, in the case of the piriformis, you may have the sciatic nerve actually pierce the lower part of the piriformis. In that case, you would completely be on the piriformis by itself, but you would still have the patient do the same motion, flex the hip, then extend the knee. Although the sciatic nerve doesn't actually touch the sacral ligaments, what I'm going to do is place my contact thumb in between the sciatic nerve and the sacral ligaments. What you may find is that all of that tissue from the sciatic nerve medial to the sacral ligaments can be bound up so that the nerve does not slide distally as the hip flexes and the knee extends. So I'll put my contact just lateral to the ischial tuberosity and then go proximal, so I'm in the area of the sacral ligament, sacrotuberous sacral ligament, right in here. Proximal tension, the nerve is just lateral to my thumb and the ligaments are just medial to my thumb. Then I'm going to have the patient flex the hip and extend the knee, bring that leg all the way forward. If it's difficult, I can step forward and help it move while I have a proximal tension in between the nerve and the ligaments. When you get about halfway through this, right here, if it's all bound up there, you'll start to feel, as the nerve goes this way, it'll start pulling that tissue distal with the nerve, and that's when you really have to block the tissue proximal as the nerve goes distal. The pudendal nerve can be entrapped in several places. The first that we'll address is on the medial end of the obturator internus, conceivably the gemelli as well, but we'll think of it as an obturator internus. So what we're going to do is just simply an obturator internus move this way and then rotate the femur. But I'm going to concentrate my tension on the medial end of that muscle where the nerve is crossing the muscle. So start here, take my tension proximal and medial along the muscle, hold the tissue proximal, and then the patient will flex the hip, and then adduct, drop the foot, and then if I need to, I can just help that internal rotation or external rotation by moving the foot down. My contact right on the medial portion of the obturator internus. Now the second place that the pudendal nerve can be entrapped is on the medial border of the ischial tuberosity. Line your back if you would. Now this will be a little hard to actually visualize, but what I'm going to do is I'm going to move into this position and then move my contact onto the medial side of the ischial tuberosity. So the ischial tuberosity is here, right where the hamstrings come to attach, so I can follow the hamstrings down right where they attach, and then move really to the medial side of the ischial tuberosity here. The second place that will address the pudendal nerve is on the medial side of the ischial tuberosity. So we'll start with the hip relatively flexed, and I'm going to follow the hamstrings down to the ischial tuberosity and then go to the medial side of the tuberosity and exert a tension proximal and a little bit posterior. But my thumb is actually going to be on the surface, the medial surface side of the ischial tuberosity. Then I'm going to flex the hip, abduct just a little bit, and hold that tension and cover that medial side of the ischial tuberosity with a tension that's proximal and posterior. That will cover the area of the pudendal nerve that's usually described as a burning in that area itself. The internal portion of the pudendal nerve, or on the pelvic floor, is very difficult to treat, even if you can find it with your hands. You're going to find it on either side of the sacrospinous ligament. But once you can put your fingers on the pudendal nerve, everything is slippery there, and there's not really a way to get the pudendal nerve to really travel. So what we're going to do is do a psoas type maneuver with the leg, and you're going to try to press on the nerve and then roll your hand to generate some tension to try to pull on all the tissue, including the pudendal nerve, to stretch it and get some tension off of that area. The way we'll find that is we'll start as if we're going to do a psoas maneuver, and I'll go across the iliacus and actually across the psoas. So I want to make sure I'm behind the iliac vein and artery, but cross over the psoas. So I'm going down on an angle of about 45 degrees. When I cross past the psoas, then I'm going to push the psoas lateral just a little bit. Then I'm going to go inferior to the floor of the pelvis. When I get to the floor of the pelvis, I'll feel a real hard spot that's on an angle like this. That's going to be the sacrospinous ligament, which is right here. Now I'm going to pick and go on the anterior side of that or the posterior side of that, whichever happens to be the tightest and the most firm. This case happens to be the posterior side of it. So posterior to the sacrospinous ligament, onto the pelvic floor. Then I'm going to roll my hand in like this to generate some tension on it, and then the patient's going to do a psoas maneuver with the leg. So extend the leg behind as far as you can go while I roll the finger and try to pull tension on the floor of the pelvis. Difficult to get to, but even more difficult to actually generate tension on the tissue. But sometimes this will relieve the tension on the pudendal nerve. My experience is about 50% of the time you can relieve a pudendal nerve syndrome by getting all three of these sites. The superior gluteal nerve can be trapped just deep and on the inferior margin of the gluteus medius and minimus. We'll basically do a glute medius minimus treatment, but we'll concentrate on the inferior border of that. So we'll be just above the piriformis in this area. Start with hip flexion, knee about 90 degrees, adduct the femur just a little bit, and I'll use my foot to externally rotate the femur and then just push the edges of the gluteus medius and minimus up, trying to roll my thumb underneath them at the same time. Once in a while, the posterior cutaneous nerve will be entrapped right on the inferior margin of the gluteus maximus. So right in here where it peeks out from underneath the muscle will be the entrapment site. We'll basically just do a gluteus maximus treatment, but we'll concentrate right on the tender spot and the little knot where you find the cutaneous nerve. Very difficult to find unless it's actually a problem. Okay, go ahead and flex the knee as far as it will go, and I'll just kind of lift the glute max up this way and tension it a little bit proximal. The genitofemoral nerve and the femoral nerve will go around or through the psoas. The genitofemoral nerve will actually go through the psoas in most people and become superficial to that muscle at about L4, L3, L4. The femoral nerve will be behind the psoas and come out in between the psoas and the iliacus lower, way down low in the pelvis, about this area right in here. The treatment is going to be the same for both of those with the exception of the location of the contact. So for the femoral nerve, I'll be on the lateral edge of the psoas against the iliacus and slide up the iliacus to the lateral edge of the psoas, take a proximal tension and hold it there. And then the patient will extend the knee and the hip all the way back behind me, and I'll hold that psoas proximal while the nerve goes distal. The genitofemoral nerve will be right at the level of L4. I'll put my contact right there on the middle of the psoas, take my tension proximal, and then the patient will do a psoas maneuver with the same, extend the knee and extend the hip. And I'll maintain my contact point right in the middle of the psoas there where the genitofemoral nerve comes through. The saphenous nerve can be entrapped in the adductor canal. One of the common sites is right over the vastoadductor membrane. So we'll do a vastoadductor membrane treatment, but what I'm going to do is move the sartorius out of the way, come up proximal till I'm on the vastoadductor membrane, hold my spot on the surface of that, and I'm going to feel for the nerve being pulled distally. So I'm going to hold the membrane proximal and hopefully the nerve will go distal. Then I'll abduct and flex the hip and then extend the knee which will pull the saphenous nerve distal. The saphenous nerve can also be entrapped between the sartorius and the gracilis. So what I'll do is I'll put the leg in a position where the gracilis and the sartorius are relatively short, but I'm going to find where they come together and they just start to separate, go back to where they're just together, and then I'm going to push anterior on the sartorius and try to wedge my thumb in between the sartorius and the gracilis, lifting the sartorius out of the way. Then I'll put the leg in this position, roll my thumb to take a proximal tension, and then abduct and flex the hip, then extend the leg. So the saphenous nerve will be coming distal while my thumb is in between the two muscles holding them proximal.